lethargic patient, basically almost non-responsive, and has no background, right? So clearly the patient has something going on. You just not encephalopathic just because, right? And you cannot fake encephalopathy, right? And I'm using your name last week, but you might it's not because you did something wrong or anything like that.
Okay.
But because to learn to learn the process, we're always learning daily basis. Everybody learns. I keep trying. We're doctors, and this is a learning process until we croak. You know, I mean, that's it. That's just the way it's gonna be, right? So EEGs for some people is like all the squiggly lines, and it's like what is that, the Matrix or something like that? All right, and it truly is not. It truly is more something more easier to understand. So we're going to talk today about diffuse encephalopathy, not lateralized or focal or anything like that that we can also find on EEGs, and that's what the EEG is useful for. And the famous or infamous bipolar montage with there is way more than 20 electrodes there. So this is possibly a maybe like a 48 electrode bipolar montage. We also call the double banana because as you can see, there's nice two bananas there drawn there, so it's called double banana. All right. Usually, it's probably is more. If you have more electrodes, the chances are to try to capture more epileptic abnormality and possibly a pre-surgical patient. So what can change the EEG? What can bring the EEG down? Right. So obviously infection. We have a gentleman downstairs with ALS and with pseudomonas, possibly septicemia and pneumonia, UTI. Right. And I looked at his EEG today, and it shows an encephalopathy that is pretty significant. Metabolic derangements, hypoxia. I think I'll talk about a little bit about each, but if not, you can always jump in if you guys want to add something or questions. You know, this is not official, but it is official, something like that. So this is I'm giving it, right? So and the many uses that we can use the EEG is also to assess the hypothermia, right? And we have the protocol here, which is now called temporal targeted control. Um, because there used to be now a real hypothermia being from like 33 to 35 degrees, but now we use 36. Is that right? It's just to avoid fever, and that's what it is. And to save money on multiple labs. All right. The utility of EEG monitoring, assessment of coma in the absence of no clinical manifestation, to detect vasospasms, hemorrhage, ICP elevation, seizures, non-convulsive seizures, and status epilepticus. Um, how can we detect vasospasm? But obviously, because there is decrease of blood flow into the brain, and therefore there will be a slowing on some areas of the brain during these events. Okay, so usually do it for we can do EEG monitoring patients who undergo, especially carotid endarterectomies, and then actually it's very useful if you have somebody looking at it. You don't have somebody looking at it, and it's not going to be useful, right? Telling you from our experiences. All right, so encephalopathy trends. So we were talking about the guys from ICU came earlier today, and then we saw a patient with encephalopathy, and this how is this encephalopathy can change throughout the days or no change. That is important for the prognosis of these patients. Right? So prognosis, sedation. Okay, we always have patients with post-traumatic. It has to be placed on propofol, and then you can assess the degrees of to what level either the critical care doctor or the epileptologist or whoever taking care of the patient, how deep they want it to be sedated, and they usually try to go for the burst suppression pattern that we'll talk about. Um, there's also very important information that you need to obtain to understand an EEG. Usually, if you want to read something objectively, I try not to get too much information. I just start looking. I just know the age. Most of our patients here are above the 30, I would say, and up to 90. So pretty much everybody's an adult. So the age is important, but also critically as if you were on a pediatric service that can change from 0 to 80 years old dramatically. All right. So temperature always is important because hypothermia can slow down brain signaling. All right. We can see that with we're talking about evoked potentials today. For example, people who do OR monitoring, hypothermia or lower temperature can slow down, and the brain waves towards the periphery. Level of consciousness, always the patient is alert, talking, and medications, obviously, especially CNS active medications. Clinical history, yes, it's relevant, but I usually don't pay attention until afterwards, and maybe I read it. Depends. Um, so patterns associated with the generalized encephalopathy. So generalized slowing. It could be the different ranges of the brain waves. Um, that we can see, is it theta, is it a combination of theta delta, or is it continuous, is it rhythmic? Are there associated all the type of discharges with this encephalopathy, like periodic discharges or triphasic waves, um, and so on? We can also see faster frequencies associated with that, and even normal frequencies that are also seen in coma, like alpha coma, beta coma, spindle coma, all those things. You would think that alpha is normal, but the patients who are comatose may have to choose alpha. There would be an alpha coma or alpha theta coma, even beta coma, right? So I'm talking about all these different names, but the students, do you know? Did we talk about? Yeah, we talked about the ranges, right? Did we talk about the ranges last week when we were there briefly? All right, so from 0 to less than 4 is delta, from more than 4 to less than 8 is theta, from more than 8 to less than 14 is what? Alpha, alpha, alpha. From and then what beta goes from what to what?
Like 14 to 20, but then there's better one and better two.
Beta one, beta two. What does beta two goes for? And so what beta two? It's almost like 8:30, and then after that is gamma, right? Okay, and then we usually look the EEG in the regular basic settings is up to 70 hertz, the higher frequency, and the lower frequency is 1. So that's all the standards. And usually, like even in the test comes out what are the settings that you use. So 1 hertz, 70 hertz test. All right, but in reality is that our brain has multiple higher frequencies, and we're not only on one frequency. Okay, we're like the matrix. We're multiple different frequencies, one on top of each other, right? But the ones that we can see to the naked eye are the ones that we just mentioned. But you can on these regular EEGs, but if you place a subdural or electrical corticography, you will be able to pick up higher frequencies up to 500s. All right, and those are the high frequency oscillations, the ripples and the fast ripples, right? Who are now in vogue because of this, are consistent with if you have high frequency oscillations on top of underlying spike wave activity, this is likely most likely the most electrogenic focus. The idea would be in the future to try to capture those high frequency oscillations on the scalp, right? And that would be great. So you don't have to open people's skull to do a subdural electrodes, right? And try to associate it with the frequency oscillations and history and some other studies like MRIs, obviously functional MRIs, SPECT scan, and try to do surgery like that without opening people's skull for days. All right. So yes, those are the things we can see. It helps to localize the anatomic localization of the abnormalities. You can assess subcortical white matter dysfunction. Um, so slowing of the PDR with intermittent rhythmic delta indicates cortical and subcortical dysfunction. So what's that, Joe? Can you tell me what's slowing of the PDR?
Uh, the posterior dominant this alpha like is like slow. So normally when the eyes are closed, there is this like alpha like band like activity like 8 to 12 hertz. So yeah, so what I said is that the when the eyes are closed, there is this like alpha level activity like in like occipital regions, um, and there is like a gradient. So this alpha level activity is strongest in the occipital region, and it gets like weaker as it goes to the anterior region. There's the anterior posterior gradient in this alpha rhythm, and the alpha this peak is like moving to like a lower like frequency range.
Yeah. Okay. So it's fine. The reason I put Joe on the spot is because he's going to an epilepsy fellowship pretty soon, and he needs to go get these concepts and try to experiment in and easily without getting frustrated. You're doing good. All right. So I think I talked to Michelle last week about PDR. So our brain has an anterior posterior gradient, anterior being slower, posterior being faster, and that's called the posterior dominant rhythm or posterior dominant. Posterior dominance. That means our brain works at higher amplitude on the back. And when we have encephalopathy or slowing, there's always a slowing or disappearance of this posterior dominance rhythm. Okay, and then when you start the alpha starts to go away, you start seeing slower rhythms on top of that. That indicates an encephalopathy. Okay, but it also can indicate that there's a diffuse brain abnormality. And I was telling, I think also you guys that were there last week that, or that if you or that if you have an encephalopathy, including with frontal lobes slowing, that we call FERDA. You guys are aware of FERDA, right? But what does that FERDA indicate? And this is for the rest of it. If you want to jump in, we can jump in. Huh?
So we need to like
So what is it? So frontal FERDA, what is that theory? Do you think the FERDA will indicate that the frontal lobe is malfunctioning? So it means, first of all, a diffuse brain damage. All right? Brain damage. That's a Pink Floyd song. And and it indicates that it could be damage. You can have damage from the brainstem all the way to the thalamus, not just the thalamus. All right? And it does create a normal functioning of the frontal lobe. But the frontal lobe dysfunction is coming from within, not just focally. Usually, when it's focal lobe dysfunction, it's usually one side more. Okay? But if you see bilateral further, then what indicates is it's part of the encephalopathy, is brain damage, and it could be also coming from within. It's brain. Okay, brainstem, very variable, rhythmic or arrhythmic delta slowing, diffuse spindle activity, or impaired patterns of arousal. Um, Electrographic seizure activity is considered a cortical pattern, although rhythmic generalized spike wave activity, absence seizures, is influenced by the thalamic oscillations of subcortical. Everything I said.
What are the leads that you see?
What are the leads? The cortical leads.
Oh,
Yeah, that's what it's trying to tell you. The brainstem or the which area of the brainstem would be activating the cortex.
reticular.
Oh, that was asking her.
Oh, sorry.
Which one? The reticular activating system. So the reticular activating system is a network that keeps us aroused, unconscious or unconscious, right? It goes from the reticular activating system to the thalamus, and specifically which nucleus of the thalamus? Anterior, right? Anterior. Why is anterior? It's obvious because it's going towards the front, to the forehead, to the front, to the frontal lobe. That's why it's the anterior. So remember it like that. These are all Penn Station, right? Penn Station is thalamus. So if you're going north, then more likely it's going to be the anterior nucleus that's going to go to the front, right? Right, just like the occipital area and the optic radius. So, all right. So, yeah. So that influences the whole diffuse pattern. That's what people used to talk about: deep-seated nucleosthalamic seizures, things like that, even brainstem seizures. I'm still not very convinced that it can happen, but I have a friend in Brazil that studies that. And he decapitates the animals and leaves the brainstem, and he's able to look to the brain activity from the brainstem, brain activity. So I forget his name, but you can actually find all this stuff on the public. Right? Brainstem seizures. Okay, so descriptive patterns of generalized encephalopathy. Okay, So is it generalized? Is it bifrontally predominant, occipital predominant, midline predominant? All right. That could also tell you many things. Occipital probably in more in younger population or older population, geriatric or Alzheimer's. Frequency, the ranges of the encephalopathy that we talked about, delta, theta, alpha, beta, right? Um, Again, you can have alpha range, doesn't mean that it's normal. You can have diffuse alpha on a patient who's unresponsive and comatose, right? In like the alpha coma, all right? Amplitude. So voltage ranges of the predominant frequencies in microvolts. So it's basically the altitude, the height of the wave, all right? And then if the important thing is there a symmetry between one area and the other beyond the normal, all right? So now let's talk about amplitude. Lashmi, why is the amplitude difference? This is a little bit parenthesis. Why is the amplitude difference in the posterior dominant area on one side or the other? And which side is higher than the other? Yeah, which one, which side is higher on the PDR? What about you, Jeff? Huh? The non-dominant? The high, you think the left? I think it's the right. It's the
I don't
right.
know. I was
It is called thickness. The one theory is called thickness and the transverse sinus of influencing that the amplitude. Just that. So, the what?
That's what it's higher in
And
the
kids?
population.
Yeah, which is yeah, most likely is the thickening of the skull. Absolutely. Um, the important thing is that there is no. When you look at asymmetry and amplitude, is there has to be more than 50%. Duration, time in seconds, minutes, or hours that a pattern is present. Reactivity, we talk about reactivity all the time, right? Especially people who are encephalopathic in the ICU. So basically, it's a change in voltage, frequency, curiosity, rhythmicity, and all these other parameters in response to a stimulation. Usually, it's noxious stimulations, but you can also do loud stimulation, verbal stimulation, noxious stimulation, robotic stimulation, right? Um, Identify the stimulus. Okay, so like you can open the people's eyes while the patient is comatose. Um, etc. Suctioning is also a way to stimulate things. So the waveforms that we see on encephalopathy, triphasic waves, spiking waves, slow wave, polymorphic, monomorphic. And if you read my EEGs reports, I include all these things, polymorphic, monomorphic. Um, when we should sometimes we describe the when it has a notch distribution on the on some areas of the waves or the wave patterns. Usually these notch are normal variants, the notched waves. The regulation is it rhythmic, non-rhythmic? Is it evolving, changing patterns, voltage? Symmetry is one side different than the other, or one area of the brain different than the other. Synchrony, are they happening, the slow or the combination of both the bilateral waves, are they happening at the same time, one or the other? Or, for example, when we see triphasic waves, they're always synchronized in the frontal area, all right? Um, they appear sometimes very aggressive, but they could be synchronized or asynchronous like biplets. Biplets means bilateral independent periodic lateralized form discharges. Biplets. The I is for independent. All right, so independence. Okay. Generalized theta slowing. These are the common causes there. All right, just go briefly. Theta slowing, metabolic sedation, systemic infection. All right, intermittent rhythmic delta activity. All right. Um, it means also, most of these things are going to be metabolic, deep hemispheric lesions, increase intracranial pressure. So when we see the slowing, but it just looks very slow, but it's not rhythmic, that's what it's telling you. Sometimes when there is a lot of delta rhythmicity, it could be epileptogenic, especially if it's lateralized, but that would be a lateralized, not the diffuse encephalopathy, right? So if it's a rhythmic delta, it could indicate an increased ICPs, right? Something that we don't forget. Continuous, talk about the next one, continuous high voltage delta slowing. So this is non-rhythmic. So we're talking about diffuse subcortical white matter dysfunction, metabolic encephalopathy, TBI, sepsis, okay, or encephalitis, diffuse. Prominent beta activity, the fast activity, all right? Benzodiazepine, right? So we see it frequently here and everywhere because the use of benzodiazepines in the hospital and out of hospital population. Alcohol withdrawal, all right? Um, alpha coma, I'm going to go a little faster because there's a lot of stuff. So alpha coma, so it's drug-induced coma, brainstem lesion, anoxic encephalopathy. Triphasic waves, everybody loves the triphasic waves. Metabolic encephalopathy, truthful Jacob disease can give you the early stages of triphasic waves. Um, generalized periodic discharges, GPDs, all right? Severe metabolic disturbance, anoxic encephalopathy, drug overdose, late status epilepticus, barbiturate withdrawals, all right? It could simulate triphasic encephalopathy. Generalized ictal activity, basically generalized seizure activity. Coma, um, sometimes you can see twitching of the limbs that are subtle. Burst suppression, this is also that we see frequently in the ICU that is induced by propofol, midazolam, or pentobarbital. Um, generalized suppression, patient who has an anoxic, severe anoxic injury, we have this, or severe diffuse cerebral edema, like we saw this lady who underwent the Tylenol intoxication. All right. Electrocerebral inactivity, brain death, hypothermia, deep anesthesia. And I also saw a patient that include there, also with another severe hyperacute liver failure, right? So no activity in the brain. Then after the transplant, they start seeing the activity. All right, EEG reactivity. So this is an increase of the brain activity after stimulating the patient. Okay, so we'll talk about that. So here is an example of diffuse encephalopathy. Um, and basically, this is what it looks like. This is on a bipolar montage. There's no the difference in colors, but you can see that there's a little bit of slowing on the frontal areas here bilaterally. And we were talking about this earlier. I don't remember what the arrow sign was pointing, but I don't see anything severe illusion. But there's an area of that becomes a little bit more. Yeah, this is what it is. It is reactive. This is what it's telling me. So you see there is more delta activity, a little slowing, and upon this time, the patient becomes more linear, so less delta activity, so a little faster. Let me see this. Yeah, I think that's what it is. All right. It is what it is. Any reactivity means less severe level of encephalopathy. Okay. With worsening encephalopathy, the EPG becomes less reactive. Uh, Stimulus-induced rhythmic, periodic, or ictal discharges. You can also be seen by stimulating the patient. Worsening encephalopathy, the EEG becomes less reactive. It progresses more into a delta frequency, it becomes more suppressed. And then we were talking earlier that the sleep complexes. So when one of the first things you lose when your brain slows down is the sleep complexes of the architecture. All right. So if a patient that you see is coming here for an overdose or an oxygen injury, and then you do the first EEG, and the EEG is basically 1 hertz to 2 hertz, non-reactive, and then the patient, then 3 days later, you repeat an EEG, and you see that there is maybe a vertex wave and a sleep complex over there and here and there. It could mean that the patient is actually improving and the brain is actually forming this sleep complexes. So it's a sign of improvement of brain activity. All right, so these are generalized um, periodic discharges. Um, so generalized slowing. Let me see if we can. This is basically what I've been saying already. Contributors to common ICU drugs, metabolic problems. This is very small. Progressive effects of reversible of anesthetics on EEG at the doses as the doses increase. So there's going to be desynchronization of the fast activity. So the vein usually appears as a synchronized machine, right? So as you start using anesthetics, you lose that desynchronization. So one side will appear slower than the other. You can have multifocal slowing. Um, the voltage and rhythmicity increase. meaning that as the delta starts to appear, there's going to be a higher amplitude. Okay, so the higher amplitude you will see it with the delta. Okay, the delta becomes more prominent. You can see at the end more burst suppression, and at the end it's going to be the isoelectric EEG that we see mostly in brain damage. Generalized theta activity. So usually, if you count here the waves, 1, 2, 3, 4, 5. So 5 hertz. 5 hertz associated with a lot of blinking. So that's a blinking artifact. Okay, blinking artifact. All right. So usually metabolic or drug induced. Indicators of wakefulness, eye blink, PDR when present. And this one has a PDR. If you can see, this is the PDR that we're talking about. So this is posterior. Here, remember, this is the slower in the front, okay, and faster in the back, okay. Um, Even when the patient is not awake, the EEG may be reactive, no changes of frequency and amplitude. Theta or alpha coma following an occipital injury usually have poor prognosis. So that this is mean that it's a diffuse delta activity that does not change with stimulation, with noxious stimulation. All right. This is the delta that we talk about and we see frequently, right? High voltage delta is another example. So we were saying that deep white matter lesions. We were talking about deep structural lesions when we see arrhythmic delta activity like that. So obviously comatose patients use frequencies about 1 to 2 hertz. Could be this is the high amplitude slow delta. You could still have reactivity. Um, and with deepening of the coma, the delta becomes less reactive and slower. So the thing here, you see I'm repeating a lot of things. Is for you, when you come out of this room, you will remember more because your brain learns by repetition. And that's called phosphorylation and neuroplasticity. All right? All right? That's my excuse to repeat things. All right. Okay, polymorphic delta activity. So I always write polymorphic on my EEGs. Okay, so this means basically it's not rhythmic. Like, this is what it means. People scratch their head. What the heck is he talking about that polymorphic? So this is what it means. That it's non-rhythmic. Okay, um, and it might be seen basically on what it says here over the temporal area of parietal regions, right? And this is an EEG of a 72-year-old man presented with altered mental status. And the imaging studies reveal an extensive subacute ischemic area correlated topographically with this EEG. I cannot read here, but I suppose it's more towards the right parasagittal area. Rhythmic delta activity. So we all talk about this rhythmic delta activity, terda, srda, or shreda, or oirda in children. Okay, so high voltage 2 to 3 hertz activity recorded at irregular intervals. On a background of a mild to moderate generalized slowing. It characteristically is frontal predominant in adults, all right, terda, all right, and attenuates with eye opening or alert. Um, Frontally predominant. Okay, so this is the what? Third, all right? Very good. And then it's intermittent, and it's rhythmic, and it's delta, all right? Early studies suggest that third might be associated with acute head injuries, tumor of the posterior fossa, you see? So very far away. Third ventricle, deep midline lesions, hydrocephalus. Uh, Occurrence of further in a wide range of encephalopathy, including focal structural lesions, diffuse brain injury, metabolic disturbance. Consider a projected rhythm from a deep structure. Possible sources are reticular activating system, okay, and the dorsomedial nucleus of the thalamus. Let's talk about the dorsomedial, but it's more than 3 or 2. All right. Further and generalized intermittent rhythmic delta. So this is generalized. All right, not just focal or temporal or occipital. Are also associated with metabolic disorders or elevated ICP. So you know you get the gist. All right. Further can occur during hyperventilation or drowsiness as well. When we do the routine EEGs and they do hyperventilation, if they have bilateral or more predominant frontal or even frontal temporal slowing after hyperventilation, that's a normal reaction of the brain. Right? So that's when people start to be lightheaded when we start to hyperventilate, right? That's what you see on the EEG. That's not the reason. That's actually this. Not the reason of the slow is not that it's the CO2, but the CO2 affects the brain in that sense. This is ERDA over the non-frontal brain regions has a distinct clinical implication. So TERDA, when you see TERDA, is more implicated with epilepsy. It's more clearly epileptic on the activity, and it's comparable to a spike level. Right? So if you see TERDA, left TERDA, then it's like the person likely has uh, epilepsy. Okay, periodic patterns. Let me see if I can. So this is the periodic patterns. What they're saying there is the what intermittent more epileptic from discharges. So the stereotypes recurrence of paroxysmal complexes at relatively fixed intervals. Okay, um, not all these periodic generalized discharges are epileptiform. So they changed the acronym to GPDs instead of GPEDs because people will think that it will be epileptic if you write epileptiform. Not all of them have epileptiform. This could be because of severe trauma, anoxic injury, etc. Okay. Um, Usually given an EEG, the morphology and duration are consistent. The interval between complexes usually lasts 1 to several seconds. Um, Additional superimposed rhythmic activity of any sequence is called GPD plus. This is for rest. You don't have to memorize any of this. Periodic patterns may occur with generalized laterals of vocal distribution. So this is a clear example here of a generalized periodic discharge. Actually, what have a better prognosis? Generalized periodic discharges or lateralized periodic discharges? Which one? One person. You said lateral has better prognosis? More likely not. I think more likely have a better prognosis to have generalized periodic. Okay, clinical correlation. A specific disease state, usually the setting of severe acute or subacute encephalopathy from a variety of causes, including anoxia, hypoxia, drugs-induced hypothermia, non-convulsive status epilepticus, encephalitis, sepsis, severe metabolic encephalopathy, withdrawal states, um, drug overdoses, barbiturates, baclofen, that we use a lot. All right, and we have patients that come here lethargic significantly because they're overdosing baclofen. What is SSPE? Okay, measles. And who can tell me what it stands for? Yeah, so even this comes out in the test doesn't have. And what's that? That's the same. All right, and this is actually almost like a pattern of birth suppression here with a low diffuse slowing. It's also part of that. This is what an MRI will look of a patient with a subacute sclerosing encephalitis. So there's a lot of subcortical swelling, especially noted on the MRI sequence here in the flare that you see a lot of juxtacortical, subcortical white matter, basically edema or leukoencephalopathy. Subacute sclerosing panencephalitis is a slow virus infection of the CNS associated with prior measles infection. The onset generally occurs in late childhood or adolescence and is usually characterized by insidious onset of mental deterioration in myocardium. Progression over a period of months to years to generalized convulsion, dementia, trauma, and death. Has anybody seen any case of this? Anybody ever? Me neither. I've never seen. Measles.
Maybe the more people don't vaccinate.
The anti-vaxxers.
Yeah.
Anti-vaxxers.
It's true.
So is there a difference between the incidence of autism in people who are vaccinated and non-vaccinated?
No, the study was completely.
All right.
It was just to get money for like a vaccine company. I think that was gonna like quote unquote like safe vaccines.
The researcher had like the share for that company. Right?
That was the guy who.
They do that for Lyme disease.
I'm,
So they don't even make it.
I'm not saying
Lyme
that
disease
pharmaceuticals are
was
angels.
No, but they currently do.
That's the devil. That's pharmaceutical companies.
Right,
But
but we
this
still
case,
have.
I mean, they put mercury in some of the stuff.
GSK level.
Somebody got especially with it.
Sucks.
So, these guys are also not to play with. But yeah, I don't think obviously the vaccination thing.
I thought it was because they were the pharmaceutical company wanted to make them that was not.
Rocket free or something.
Yeah,
like that.
Mercury
not-
free.
I was talking to, back when I was in Taiwan, even our neurology doesn't want.
Well, I don't want my flu shot because it doesn't work.
Yeah, but they don't want it because they don't want to get MS. That's like
That is
10 years ago.
completely
That's 10
false.
years ago.
It's not
Yeah.
MS, it's GBS. All right?
That's
Guillain-Barré syndrome. And people will say, oh, it's because of the flu vaccine I got GBS. If you look at the PubMed, you find an article that proves that and it's short to me and both.
no, I don't trust her. I'm just saying it because
So it's not MS.
well, they
GBS.
say MS. but I don't know
MS.
where they come from.
No.
Adam.
Hmm? Adam with some vaccines in the children. It's possible. CJD. So you see the difference. We also have generalized periodic epileptiform discharges or generalized discharges. Okay. So shorter interval between the discharges is typical. Nothing's typical, but it's saying that's typical, right? But you will never see, oh, this is okay. This is CJD. But you have to think about it with the history and everything, all right? Rapidly progressive dementia. I think we had a case here, and we may have not realized. The
The
guy,
guy who also.
yeah.
That poor guy.
Yeah, he had because he also did he have a bleed too on one side?
He
It's
has
subdural.
bilateral.
Bilateral.
Yeah, and then they were saying we're not seeing the epileptiform discharge because it's subdural, but yes, we did see it in the beginning. Right? So I think his brain was just.
He said epileptic or it's always class. I thought it's always class, but rhythm is very long.
I'm sorry, say that again.
Was it always Pledge or was it epileptic one too?
I think he had seizures too.
The plants is epileptiform, right?
We only read it as
Yeah,
Yeah,
but
generalized
I read, no,
epileptiform discharge.
I read it as Pletz Plus. Who was with me rotating? Who was it with me? Was it you? Was Joe?
It's like,
Come on.
It was Pletz.
Oh,
Was
you
Pletz
just
Plus,
took care.
right? Pletz Plus means that it's a place that causes seizure associated with seizure in the same area of the plants.
You don't think he's because seizure didn't work for work and then he died.
Seizures, he had no seizures. He was monitored.
But he
He was
wasn't
on
starting
LTM for a
monitor
long time.
until I think a couple
Oh,
months when he
so
came here.
okay, so what you're saying is that initially when he arrived, they let him see for like days.
Before we get there.
Before
Uh,
yeah, I remember I discussed with somebody. It's like, oh yeah, sure. I don't know.
Because we all very bothered by this case.
Yeah,
And it
'cause
was
we
like
don't know what
neurosurgery was
happened.
never on board. I don't know whether take the subdural will help him at all. It won't.
It was the subdural was looked like more like hygromas too, and then
It does
like,
look more.
you know, and then I don't know, draining that. I don't think it was gonna be.
Dr. Seuss, this patient, he had these generalized periodic discharges, and then his AG went really flat.
Yeah, I think it's
Sounds like
because
he was dead.
I think that it's because he's. That's what I'm saying. That's what I'm trying to say. I think no, it's just the brain starts to die and shuts down, and it's not like I'm like. I remember seeing him clinically in the first EEGs, and the EEGs were correlating with his clinical activity. And then the EEGs, he was having some type
The
of
twitching.
the twitching of the tongue stuff. I think he was biting also in the tube. Because I was there, we're looking at it. I was not convinced that they were all like automatism, like you guys were calling it. But anyway, this is yeah. Too bad we didn't do 14 EE and try to find out. I mean, people are sometimes afraid of ordering this test because it's gonna create drama, but who cares about the drama, right?
What opportunity?
Oh my God, we have to clean the freaking room. We'll clean the freaking room. You know, I mean, it's better. Yeah, well, he died, but the family understand didn't want to do the autopsy. And it's a spongiform, encephalopathy, CJD, all that stuff. I think you need to clarify. And if people are whoa, we're not going to do anything because it's going to contaminate the room, or like he's been hanging around for how long? You
We
know,
we tried
We were all
bedside LPs
contaminated.
on him.
I don't know. First of all, CJD just I don't think it contaminates anybody like just like touching.
How about CSF?
Because if you had
This one is the one that
I
didn't
touched
help
the
me.
CSF.
no, because it's
Two.
I mean, did you pinch yourself?
I didn't.
Okay. Well, the thing is like if CJD was so contagious, why don't we have more cases of that?
Yeah.
The blood-brain barrier has to be violated.
Right? Why don't we have more? Oh my God, CJD, you have to clean out all the object. So, but the patient has been hanging around the streets for how long? Why don't you have an epidemic of CJD coming into the room, right? If it's so infectious, as people say, right? So it's not as infectious. It has to be a particular thing that I don't understand. It could be some type of protein that affects the fans or mutates in certain people. I don't know, but things are not just as simple as highly contagious, which is not. Highly contagious is the flu, right? You know. So anyway, so this is early in the disease. It could show generalized slowing. All right, with several months, periodic discharge starts to appear. Then generalized asymmetric discharges and can be unilateral. Okay. All right. Myoclonus is not time locked. What does that mean?
Like it doesn't happen rhythmic.
Sequence with what?
The
The
EG.
EG.
So you mean the discharge and then myoclonus?
That's
Yeah.
what you said. You said that when you saw him, he was in pain.
Yeah. So, but this okay. No, we're talking about yeah. So the time lock means at the same time with the discharge, you see that. Like our patient downstairs yesterday, right? We haven't been downstairs, but looking at the EEG, but you see the pulse spikes. They just sleeping and go. And then stop, right? It has an electrocution, right? Basically, right? And then yeah, and this is exactly what it looks like, and it's a tonic myoclonus. Tonic because he's raising his arms. That's you see that tonic. That's the tonic myoclonus. Boom. That's tonic. That's the tonic troncotonic. All right. All right. So EG criteria used in the diagnosis of CJD. Periodic sharp wave complexes. Periodic most important periodicity most important criterion. Frequencies between zero point 0.5 to 2 hertz or 0 seconds. Duration between 100 and 600 milliseconds. Amplitude higher than 150 to 300. Generalized activity with maximum over the frontal region and partly also lateralized, sometimes followed by burst suppression. These are the different changes you can see with CJD. 40 days after disease onset, 80 days, 110 days, and the brain is burned at the end.
Well, that leads to the That's always half the year.
So 160 days from the beginning to die, that's pretty fast and progressive. What do you think is going to be like 4 days?
It's slower than Stallone.
Maybe slower than- But you don't know how long.
No,
Yeah.
But
he
remember,
had a
he was
seizure
in
London.
yeah, he was in
in
Europe
London.
for that convention.
But he complete back to baseline.
Was he?
When it
Yeah,
started,
He's
it
complete.
started. And then I don't know if it's because you
But
never,
that's also
never
2
talked
weeks
then.
ago.
Yeah, this is, see how many cases of CJD it took. Let's have a trial of CJD. You never see that because there's not that many people die. So this is what people can gather through literature and things like that. All right, so yeah, it could be 40 days, go to 60 days, and this could go faster. The incidence is like 1 in a million, right? CJD and sporadic MRI, right? So you can see here the lenticular nuclei, pelvic, right? So it says, what is this? What is it? I cannot read. What does it say?
Mark hyperintense signals of found posterior
Hockey stick.
Where is the pelvic sign?
The lower.
The little things like here,
Hockey stick, right?
almost close to the mammillary bodies. So the pelvic sign is classic. We were talking about the pelvic sign, so learner sarcoidosis too, also maybe. Fabry's disease.
Did this one have it? No,
He doesn't have it.
Oops. So this is the cortical ribbons, right? And he had cortical ribbons. All right, he had cortical ribbons. I mean, it's just like, man, why do you guys know? Okay. Well, listen to what it was.
But this seizure itself can cause cortical.
Yeah, it's true. But then, but you know what the patient has. You know what I mean? No, you don't know what the patient has. Yes, and we've seen our famous lady with an MBA encephalitis. She had beautiful cortical, right? And the same area correlated with the ED with beautiful. All right. How's she doing? That patient.
It looks like she has belly to one thing like
Oh. I mean, she was basically touching the. She was talking to St. Peter upstairs for like a few days. All right. For the numbers. So she did pretty good. Incredible. That was an amazing case. The prognosis of generalized periodic pattern depends on etiology. Cardiac and respiratory arrest are common precursors to cardiac to anoxic encephalopathy. This pattern is strongly associated with poor outcome in the pulse rate. Are you talking about CVD still? Oh, yeah. GPD's myoclonic status epileptic within 24 hours of a primary circulatory arrest. I don't think we're talking about CVD anymore. I think we're talking about GPDs. Generalized periodic discharges plus myoclonic status epilepticus within 24 hours of a primary circulatory arrest. The prognosis is invariably poor. All right. In myoclonic status epilepticus, the myoclonic jars are synchronized with the periodic discharges of bursts. Use paralytics. Why did I put that in? Because we get an EEG and all we see is muscle. So there's like, if you use a paralytic, they will make my life much easier. And then I will be able to read the EEG and tell you what. Source localization of periodic sharp waves. Maybe that was associated with CDD. This is one I haven't seen this talk in a long time. Source localization of periodic sharp waves work complexes using independent component analysis as periodic CJD. All patients showed dipole sources responsible for periodic sharp wave complexes of CJD in both the cortical and subcortical deep gray matter. These findings suggest that basal ganglia and thalami, as well as frontal cortices, are involved in generating periodic sharp wave complexes in CJD. So we talk about the pulvinar sign, the thalamus, and the basal ganglia involvement, and we saw the MRIs. That's what these papers do. Triphasic waves. All right, so let's not spend too much time here, but this is a metabolic encephalopathy with spike and slow wave, or sharp and slow wave that are blunt and wide. All right, look like almost like a Z on the side, right? Z. All right, Foley also described the bifrontal predominance of 2 Hz frequency. I'm sure this is not the same Foley from the Foley cathode. Okay, in 1955, Blickford and Butt coined the term triphasic waves, focusing on the prominent positive wave. Oh, just to make sure, a little parentheses. Devic. You guys know who Devic was?
Dira?
Devic, D-E-V-I-C. Devic.
The one
David
that-
is the animal. Oh, yeah.
Devic.
No, the big is the one that's children epilepsy disease.
Devic disease. What is Devic disease? Animal. What is animal for?
Neuromyelitis
Okay. His fellow was the one who coined the term neuromyelitis. I forgot when he put in there.
Who coined the term?
Huh?
Fellow. So the attending is still the fellow is like a credit.
Oh, it's neuromyelitis optica. Oh, yeah, it's neuromyelitis optica.
It's my disease.
It's my disease. Actually, it was probably they describing it really well. He said, well, it's involved in neuromyelitis. And then I said, oh, yeah, very good. Nice cognitive disease. In 1955, Wilford and Rudd coined the term triphasic waves, focusing on the prominent positive wave, pointing downward, preceded by a low amplitude negative and followed by a negative wave. So it's negative, positive, negative. All right, it's like an M with the largest, the deep. That's the positive wave. Positive, small positive, large positive. Sorry, small negative, large positive, back to a small negative. I know you guys are triphasic waves, typically bifrontally, like everything, because of this thalamocortical pathway. Include 3 cases of negative component. We just talked about that. There could be a lag. You could also see them posteriorly, okay? And it may occur in brief runs or continuous pattern. Usually it's waxing and waning. This is what we see all the time. So do not confuse with generalized periodic discharges. Generalized are usually narrower or faster, right? Then the tricyclic. All right, so alpha coma. This is the alpha coma that we'll talk about. You can see that there's in the alpha range and it's widely distributed. And interestingly enough, the posterior dominance rhythm is inverted because you see a higher amplitude on the frontal area, right? Frontal. Are you guys falling asleep yet? All right. What time is it? All right. Let's try to. Oh, we're almost done. Okay, cool. So alpha coma, 8 to 13 hertz activity in unresponsive patients is termed alpha coma. Can be seen after post-anoxic injury, brain stem, stroke, head trauma, infection, sedatives, metabolic, like everything, right? Maybe generalized or with anterior posterior dominance, like we saw, does not react with eye opening or noxious stimuli. So the patient needs to be basically unresponsive, comatose 3 out of 15, that's on the scale. Can have variable reactivity when present. Can be seen intermixed with slower activities, theta, coma, sometimes it's even called alpha theta coma. Yeah, there it is. Share the same individuals with similar outcomes. So this is the beta coma or spindle coma, right? We have seen here some, and the spindle coma, and that's it. All right. Let me try to. Yeah. What?
Stephen
Stop
Stephen has to do it.
You're on a anchor, man.
Yeah. All right. Oh. Okay. Empty some water. Oh, this is. I thought I had. Thanks.